Have you ever found yourself needing to quickly grasp a really complex topic, maybe for work, maybe just because you're curious, but felt kind of swamped by all the info out there?
Yeah, trying to get the main points without getting totally bogged down.
Exactly. You want the key insights, but not, a PhD level course overnight.
Hmm.
Well, that's what we're doing today. We're taking a deep dive into something pretty critical in medicine.
Uh-huh.
We're looking at endoscopic interventions for anastomotic leaks and fistulas after gastric surgery.
Okay, so these are basically complications after stomach operations. Serious ones, actually. They can really affect how well a patient recovers.
Yeah, significant issues. And the field is moving so fast, right?
Incredibly fast, which is why staying updated is key.
Absolutely. And our guide for this is a really great recent review article. It's from the Journal of Gastric Cancer, just out in 2024.
Oh, nice. So very current.
Yeah, it sums up all the latest techniques, how well they work, the different endoscopic tools. So think of this as your shortcut. We'll pull out the crucial bits, what these procedures are, how they function, and the data behind them.
Getting you that solid overview without you needing to sift through all the dense medical literature yourself.
Perfect. So let's start with the challenge itself. What are anastomotic leaks and fistulas? Why are they such a big deal?
Okay, so imagine surgery on the stomach or esophagus. Surgeons often have to, cut and then reconnect parts. An anastomotic leak, that's when the surgical joint, that connection point, doesn't quite seal properly. It leaks.
Ah, like a faulty pipe joint, basically.
Pretty much, yeah. And if that leak hangs around, doesn't heal, it can sometimes create a fistula. That's like an abnormal tunnel forming between two places that shouldn't be connected.
Okay, so a breach in the body's internal structure. That sounds quite serious.
It really is. These are considered major adverse events. They significantly increase the risk of serious illness, longer hospital stays, and unfortunately can even contribute to mortality after surgery.
Wow.
And given how complex, say, stomach and esophageal surgeries have become, these complications are, well, an inherent risk, unfortunately.
How often does this actually happen? Are we talking rare or...
More common than you might think, actually. The article points out some pretty striking numbers. Depending on the specific surgery, leaks can happen in maybe 8% to even 26% of certain esophageal operations.
26%, that's high.
It is. And after a total gastrectomy, removing the whole stomach, it's around 3% to 12%. Even in bariatric surgery, which people hear a lot about, leaks occur in maybe 1–2% after sleeve gastrectomy and 2–8% after a Roux-en-Y gastric bypass.
So yeah, definitely not rare, potentially affecting quite a few patients. How do doctors classify these leaks? Is there a standard system, and what would a patient feel?
Well, there isn't one single definitive classification everyone uses, but they often get grouped. Like, type I might be small, maybe subclinical, hard to detect.
Yeah.
Type 2 is more major, often with fluid collecting nearby.
Okay.
They also classify them by timing acute as within a week of surgery, early within 6 weeks, late or chronic if it's still there after 12 weeks.
And symptoms?
Some patients might not have obvious symptoms, but commonly, abdominal pain, a fast heart rate, fever. In really bad cases, it can progress to sepsis, a life-threatening infection, septic shock even.
So how do they diagnose it then if it's suspected?
Besides watching the patient closely for those symptoms, imaging is key. Things like CT scans or an esophagogram that uses a contrast dye you swallow to show up the leak. And of course, endoscopy itself, using a camera to look directly inside.
Got it. And once it is confirmed, what's the plan? Is it always back to surgery?
Not necessarily. I mean, severe cases might need another operation, yes. And some very small ones might be managed conservatively with antibiotics and letting the body heal. But increasingly, for many leaks, endoscopic methods have become the first choice. They're less invasive.
Right, and that's our main focus today, these endoscopic tools.
Exactly. The techniques used to fix these leaks from the inside using an endoscope.
Okay, let's get into these tools. First up, endoscopic clipping. The source calls this a kind of traditional method. What are we talking about here?
Right. Clipping is very common. There are basically two main types. You've got through-the-scope clips, or TTSCs. They go through the working channel of the endoscope. Pretty user-friendly.
Okay.
Then you have over-the-scope clips, OTSCs. These are different. They're mounted on a little cap that actually fits onto the end of the endoscope.
Ah, so it sits on the scope, not through it.
Exactly.
Yeah.
And that design lets it grab a bigger chunk of tissue, allowing for what's called full-thickness closure. It can close defects up to about 2 centimeters.
For anyone trying to picture this, Figure 1 in the article we're looking at shows an OTSC really clearly. Imagine this small, quite powerful clip attached to a cap on the very tip of the endoscope. It's designed to pull the edges of that leak together firmly, sealing all the layers. It's actually a really clever piece of engineering for such a delicate internal job.
It really is.
So how well do they work, the clips?
Pretty well, generally. The article mentions a Korean study showing a complete closure rate of 79% with clipping. Now, interestingly, that wasn't statistically that different from stents, which had about an 83% success rate in that study.
Okay, similar success.
Yeah, but clipping often resulted in faster closure times. The median was 13 days compared to 26 days for stents. The trade-off was that clipping sometimes needed more endoscopic sessions to get the job done.
So maybe quicker healing overall, but potentially more procedures involved. Are there downsides or things to watch out for with clips?
Definitely. One key thing is that OTSCs, those over-the-scope clips, they don't work nearly as well for chronic leaks. Success rates drop to maybe around 37%.
Oh, wow, compared to acute.
Yeah, for acute, fresh leaks, they can be close to 100% successful. The problem with chronic leaks is the tissue gets fibrotic, scarred, and really tough. The clip just can't grab and hold it as effectively.
That makes sense. Scar tissue is harder to work with.
Exactly. And other potential issues. The clip could slip during placement, or if you put too many in a narrow area, it could cause a blockage. Rarely, you could cause further injury or a tiny perforation. So technique matters.
Right. Okay, so clips are great, especially for acute leaks, but maybe not ideal for chronic ones or really large defects. What about when you need to cover a larger area or keep the passage open while things heal? That sounds like where stents come in.
Precisely. Stents act like an internal scaffold or bypass. They cover the hole, directing food and fluids past the leak, allowing the tissue underneath to heal.
Ah, so it protects the area.
Yes, and a big plus is it often allows patients to start eating or drinking much sooner. Plus, it can help prevent the area from narrowing down later, forming what's called a stricture.
Makes sense. What kinds of stents are used?
Two main families: self-expandable plastic stents, SEPS, and self-expandable metal stents, SEMS. The metal ones, SEMS, are often preferred now and can be fully covered, FCMs, or partially covered, PCSMs,
Covered with what?
usually silicone or polyurethane. That coating helps prevent tissue from growing into the mesh of the stent, making it easier to remove later.
Got it. Now, figure 2 in our source material really helps visualize this process. It shows a series of images for placing a metal stent and SEMS. Image A, you can see the leak itself, the fistula, right there at the anastomosis site.
Yep, clearly marked.
Then B and C show this really critical step. They're feeding a guide wire through the fistula.
That gives you the pass, the rail to slide the stent over.
Exactly. Then D shows the stent itself, a fully covered one in this case, being deployed and expanding to cover that hole. And finally, E shows something interesting, additional clips being placed, probably to anchor the stent ends and stop it from moving.
Yeah, that's often done to prevent migration, which we'll get to. It's a great visual sequence of the procedure.
So effectiveness. Are metal stents better than plastic?
Well, a big review mentioned in the article found that the clinical success rates were actually pretty similar, around 84% for plastic, maybe 85–86% for the metal ones. No huge difference there.
Okay, so what is the big difference then?
Migration. Stent migration. That's when the stent shifts position, moves away from the leak site. And that is a major issue.
Ah, how common is that?
Significantly more common with the plastic stents, about 31% migration rate, and also quite high with the fully covered metal stents, around 26%. But the partially covered metal stents, much lower, only about 12% migration.
Wow, 12% versus 26 or 31%. That's a huge difference. Why?
The thinking is the uncovered ends of the partially covered stents embed slightly into the tissue wall, anchoring them better. Fully covered ones are smoother and can slip more easily.
That makes sense. So success rates might be similar, but staying in place is a big advantage for the partially covered metal stents. Now, you mentioned Table 1 gives more detailed data on stents. Let's dig into that because these numbers sound really important.
Yeah, Table 1 is incredibly useful. It pulls together data from a whole bunch of different studies. You see the number of patients, their age, how soon after surgery they got the stent, how long treatment lasted.
And the key outcomes, success and migration rates.
Exactly. And you see the variability. Like one study from 2022, 23 patients, 82.6% success. Pretty good. But then another from 2016, 31 patients, 84% success, similar, but a 35% migration rate.
Yeah, that really highlights the migration issue.
It does. And look at the treatment duration column. It varies a lot. Some studies show a mean of 26 days, others up to 55 days. So patients might have these stents in for quite a while.
That's a long time to have something like that inside.
It can be. And the table also breaks down success by where the leak is. Leaks at the esophagojejunostomy, where the esophagus joins the jejunum, about 86% success. Gastroduodenostomy stomach to duodenum, even higher, over 94%.
Wow.
But then leaks at a duodenal or jejunal stump, like a closed-off end of the bowel, much tougher. Only about 60% success rate reported there.
So location, location, location really matters for stents.
It absolutely does. Affects the choice of stent, the technique, and the likely outcome.
Okay, so besides migration, which is clearly a major headache, what other potential problems come with stents?
Well, sometimes tissue can overgrow at the ends of the stent, causing a new blockage or stricture. There's also a risk, though small, of perforation or even creating a new fistula. And patients might feel some discomfort, chest pain, maybe food getting stuck.
And removing them, especially the partially covered ones.
Yeah, that can sometimes be tricky because the tissue grows into the uncovered ends. It requires careful technique.
Okay, that's a really thorough look at stents and their challenges. Let's shift gears to endoscopic internal drainage, or EID. This sounds focused on infection control.
That's a big part of it, yes. When you have a leak, fluid can collect outside the bowel, forming an abscess. EID uses small, flexible drains, often pigtail-shaped plastic stents, placed endoscopically to drain that fluid collection back into the digestive tract.
Ah, so draining it internally instead of, say, externally through the skin.
Exactly. This helps control the infection, gets rid of the collected fluid, and that environment promotes healing of the fistula tract itself.
How effective is this approach?
Quite promising. One study reported 85% success. Another compared EID directly with just trying to close the leak endoscopically and found EID had an 86% success rate versus 63% for closure alone.
That's a significant difference.
It is, although sometimes the healing process with EID might take a bit longer. One study mentioned 12 months versus about 7 months for closure methods, but the benefits can outweigh that.
What are those big advantages then, especially for the patient's recovery?
Well, a huge one is enabling early feeding. Some studies show patients starting fluids within a week, a soft diet in 2 weeks. That's massive for nutrition and recovery.
Absolutely.
It's also very effective at managing sepsis, that dangerous infection.
Yeah.
And because it's endoscopic, it's less invasive, patients can often get moving sooner, potentially shorter hospital stays, fewer risks like blood clots or hospital pneumonia. It really shifts the recovery dynamic.
Sounds like a really patient-centric approach. Any major risks with EID?
Overall, adverse events are relatively low, maybe 4–15%. And usually manageable. But there have been rare reports of severe complications, like the pigtail drain migrating into the spleen, or a major blood vessel like the splenic artery. So while generally safe, vigilance is needed.
Okay. Next tool in the box. Endoscopic suturing. This sounds like actual stitching, but done through an endoscope.
That's exactly what it is. There are devices, like the overstitch system mentioned in the article, which allow the endoscopist to place full-thickness sutures, closing the defect much like a surgeon would, but from the inside.
Wow. That seems incredibly precise.
It offers great precision, yes, but it's technically demanding. It requires a lot of extra training and skill, especially working in confined spaces or at tricky angles within the GI tract. Sometimes the edges of the leak need preparing first, a process called de-epithelialization.
So a steep learning curve. How successful is it?
The data is a bit mixed, or maybe evolving. One study showed a good long-term success rate, around 80% overall, maybe 77% with just suturing, even higher if combined with other methods.
Okay, that sounds pretty good.
But then other studies found that while they could achieve 100% closure immediately after the procedure, only about 40% of those closures held up long-term.
Ah, so durability can be an issue.
It can be. It really underscores that success depends heavily on the specific defect, how long it's been there, the tissue quality, and, frankly, the operator's skill. Often it's best used as part of a combined approach.
Right, tailoring it again. Okay, now for something that sounds really different, endoscopic vacuum therapy, or EVT. Tell us about this one.
EVT is a fascinating and increasingly popular technique. It involves placing a special open-pore polyurethane sponge at the site of the leak. This sponge is connected to a suction system, creating negative pressure.
Like a tiny medical vacuum cleaner?
Sort of, but it does two crucial things simultaneously. One, it seals the leak opening. Two, it actively and continuously drains away any fluid, pus, or debris from the cavity.
Okay, so drainage and sealing.
Yes, and that active drainage is key. It cleans the area, reduces inflammation, and really stimulates the growth of healthy granulation tissue, pulling the edges of the defect together much faster. The sponges usually need changing every few days, maybe 3 to 7 days.
Let's look at figure 3 here because it shows EVT in action. Image A, again, pinpoints the leak at the anastomosis site. B highlights a common problem alongside it, a stricture or narrowing.
Yeah, leaks and strictures often go together.
Then C shows the sponge being inserted attached to a tube. And D shows it positioned right at the leak site, ready to apply that negative pressure. It really illustrates how targeted this therapy is.
It does. It's actively engaging with the wound environment, not just passively covering it.
That sounds powerful.
Yeah.
What about the success rates for EVT? How does it stack up, especially against something like stents?
The success rates reported are often very high, 74% in one study, even 100% for early leaks after bariatric surgery in another. A larger systematic review suggested around 90% success across different upper GI conditions.
90% is impressive.
It is. And the comparisons to stents are striking. One study directly compared EVT to SEMS for leaks. EVT achieved 100% success.
100%.
Yes, compared to only 63.6% for the stents in that same study. Plus, EVT had a shorter median time to success, 19.5 days versus 27 days for stents. And get this, the complication rate for EVT was 0% versus 54.5% for the stents.
0% complications versus over half. That's huge. Why such a dramatic difference?
The article explains it well. EVT actively removes all the infected material, the necrotic debris, the pus. It cleans the wound bed, stops inflammation spreading, and creates the ideal conditions for healing. Stents mainly just block the hole. They don't actively clean the cavity behind the leak as effectively.
So the stent might seal the leak into the gut, but the infected cavity outside might still fester?
Potentially, yes.
Yeah.
EVT tackles both the leak and the cavity simultaneously. It really seems to promote faster, more reliable healing in many cases. Based on this data, it looks like a potential paradigm shift for certain types of leaks.
Let's quickly glance at Table 2 then, which focuses just on EVT data. Does it back up these strong claims?
It largely does. Table 2 compiles data from various EVT studies. You see patient numbers, age, treatment details like duration and number of sponge changes, and crucially, success rates and adverse events. And yes, you see studies like Huang et al. From 2016 and Choi et al. From 2020 reporting that 100% success rate.
Wow.
And look at the mean treatment durations in those studies, 19.5 days, 15 days, relatively quick healing. Now, the table does list adverse events reported in some studies, things like bleeding, stricture formation later on, and very rarely severe things like a tracheoesophageal fistula or esophageal ulcer were seen.
So not zero risk across the board, but generally low?
Generally low, yes, but the table reinforces the overall high success rates and relatively rapid healing. The main caveat mentioned is that many studies still have fairly small patient numbers, so larger trials are definitely needed to confirm these findings robustly.
Are there factors that make EVT work better or worse?
Yeah, a couple are mentioned. Patients who had neoadjuvant therapy, chemo, or radiation before surgery seem to have lower success rates with EVT. Also, how the sponge is placed matters. Putting it right in the leak cavity seems more effective than just placing it within the esophagus or stomach near the leak. Precise placement is key.
Makes sense. Okay, one last category. Tissue sealants. Like glues.
Essentially, yes. Things like fibrin glue or cyanoacrylate glue. Fibrin glue forms a sort of biological clot. It's well tolerated. Cyanoacrylate is more like a superglue. It polymerizes on contact with moisture and actually triggers a bit of a healing reaction.
Do they work well for these leaks?
Some broader studies, not just focused on post-gastric surgery leaks, show high success, maybe up to 97%, and potentially shorter treatment times. But the limitation is that you often need multiple applications, sometimes large amounts of the sealant.
And specific to these gastric leaks?
That's the gap. The article notes there isn't much dedicated research specifically on sealants just for post-gastric anastomosis leaks. So more study is needed there to really know how well they fit into the toolbox compared to the other options.
Okay, so we've covered a lot of ground clips, stents, drains, sutures, vacuums, glues. It sounds like the main message is there's no single best option, right?
Absolutely not. The most crucial point, really, is that the choice has to be individualized. You have to look at the patient, their overall condition, the specific leak is a big, small, acute, chronic, is there an abscess? And then choose the right tool, or often the right combination of tools.
Combination therapy is common then.
Very common, especially for more complex leaks. You might use a stent and internal drainage, or maybe EVT followed by clipping a small residual defect. It's about leveraging the strengths of different techniques.
And Table 3 in the source seems to pull this all together nicely, summarizing the pros and cons of each approach.
Yeah, Table 3 is a fantastic summary. It lists each intervention, clipping, both types, stents, plastic and metal, EID, suturing, EVT, sealants, and right next to it, the key advantages and the main concerns or disadvantages.
So you can quickly see, for example, clipping, easy to use, but risk of obstruction. Stents, promote healing, but watch out for migration.
Exactly. EID reduces reoperation, allows early feeding, but potential for longer treatment, and that rare severe migration risk. Suturing, precise, but needs expertise and durability can vary.
And EVT, rapid closure, drains debris, fewer complications in some studies, but those rare severe adverse events are noted. Sealants, high success reported broadly, but needs repeat sessions and more specific data for gastric leaks.
It's just a really concise way to grasp the trade-offs for each method. Super helpful for understanding why one approach might be chosen over another in a particular situation.
It really paints a picture of a sophisticated, evolving field. We've gone from maybe just surgery or conservative waiting to this whole array of minimally invasive endoscopic solutions.
Definitely. These techniques have transformed how we manage these difficult complications. It's about providing effective treatment while minimizing the impact on the patient. But, as the article concludes, the work isn't done.
Right. More research needed.
Always. Especially larger studies, randomized controlled trials if possible, to get even stronger evidence on which approach is best for which specific scenario, and to fully understand the long-term outcomes and safety profiles.
It's an incredible amount of progress. It leaves you thinking, though, as these technologies get ever more precise, more personalized, allowing us to intervene in these incredibly complex ways, what sort of ethical questions pop up?
That's a really important point. Things like access, cost.
Yeah.
How do we ensure these advanced, potentially expensive therapies are available equitably? How do we balance the push for innovation with fair distribution of care?
Exactly. When you can tailor treatment so specifically, who gets access to the most advanced options? It's something to think about as medicine continues down this path.
Definitely a crucial consideration for the future.
Well, hopefully this deep dive has given you, our listener, a much clearer understanding of these vital endoscopic interventions and maybe sparked some thoughts about where this field, and medicine more broadly, is heading.